Hi, and welcome to Healthcare IT Today. I'm Colin Hung, and today I'm joined by two gentlemen who'll be talking to us about the importance of remote patient monitoring to population health, and specifically about the study that they're conducting. I'm joined today by Dr. Devereaux and Dr. McGillion with McMaster University here in Ontario and the Population Health Research Institute. Thank you, gentlemen, for taking the time today to talk with us.
Thank you for having us, Colin.
Pleasure to be here. Thank you.
Let me first start by asking the obvious question. What is the Population Health Research Institute?
I'll start with that. So the Population Health Research Institute is a world-leading clinical research institute. We undertake large randomized control trials. We randomize people to one intervention versus another, and we undertake large epidemiological observational studies. We have 70 researchers in the Population Health Research Institute, over 300 staff members who include biostatisticians, research coordinators, program managers, people who deal with our contracts, people who do with all of our computing issues. The Population Health Research Institute is a global entity. We do research in 6 continents. We have over 1,500 centers we work with all over the world, and we're well known for our research.
Awesome. And what's the affiliation with McMaster?
Well, the Population Health Research Institute is an institute of both McMaster University and the Hamilton Health Sciences. So we're directly connected to McMaster University.
Excellent. Thank you. Thank you for explaining that. I've always wondered what the PHRI was, so appreciate that explanation. So why is population health even more important now? I mean, obviously we're in the middle of a pandemic as we're recording this. Why is population health so vital and so important?
So in terms of population health, do you mean regarding remote monitoring within it, or just broadly the concept of population health?
Maybe we'll start with the broader, and then we'll get right to the remote patient monitoring stuff, which we're here to talk about.
Well, population health matters in the sense that we want to ensure that we do things appropriately at a population level, not only at individual levels, that will ensure the overall health of a society. Obviously, we see this most obviously at the moment with the COVID-19 pandemic, so that my actions not only can affect me, they can affect you, and they can affect your loved ones. And population health matters. It matters to all of us. We're all interconnected, and our healths also are very interconnected.
Dr. McGillion, do you have any comments around population health and why it's so important right now?
Well, I think just to follow on what PJ has said, it's really important for us to analyze what are the best solutions to the world's challenging problems. And in this context of COVID-19 and the project that we're going to discuss today, it's really important to look at what are the best solutions that we can discover, how they work, and how best to scale them. And so it's important that we look at that with representative samples at the population level to really appreciate how things can have global impact.
Awesome. Well, and you touched on it, Dr. Devereaux. The reason why I wanted to get together with you today and why I'm excited to have this conversation is this concept of remote patient monitoring, and it within the context of population health. Why is this sort of now becoming more prevalent and more important?
I think that COVID-19 has had a lot of negative consequences to a lot of us in society. At the same time, there's been some things that have actually been positive to come out of it. And one of the things I think that it has forced healthcare to do is to move forward much more rapidly with virtual care and remote automated monitoring. Even though it's difficult for anyone to imagine, there was a day when people were sick and went to the hospital, but people didn't measure patients' vitals. That seems difficult to comprehend, but that obviously was a moment in time. Obviously, when we sorted out the ability to measure people's vitals and know their temperature and their blood pressure and their heart rate, obviously that allowed us to then better differentiate who was potentially in trouble versus who looked to be doing well. And what we see is that in a moment like COVID, where having everyone come back to busy clinics or to a hospital has its own inherent risk, that if we have the ability to actually monitor and manage patients virtually and using remote monitoring technology, obviously that has a potential real upside at a population health level. The other thing too that you discover in doing this, which I suspect we'll get into in this, is that there's no doubt from a patient point of view, there's an enormous convenience. I'll be happy to discuss, some kind of cases that we've seen in the research we're doing, but I have little doubt that most people hearing those cases would say, of course I would want that type of care for both myself and my loved ones, because the convenience of it is just so much easier than having to either go to an emergency room and wait 3 to 6 hours to be seen, or go to a clinic and the cost of going to the clinic, the cost of parking, all the time spent doing it. If we could do these things virtually, that has huge potential also from an efficiency and just convenience point of view for broader society.
Dr. McGillion, do you have anything to add to that?
I think it's really about, as has been said, innovating for efficient healthcare, and what are the ways that we can look at the best models, to preserve patient health and safety, optimize efficiency in terms of healthcare delivery, and make a difference to outcomes while being attentive to reduction in duplication of healthcare services and improving outcomes related to important patient outcomes and healthcare related costs. And so I think, as Dr. Devereaux said, remote monitoring is a real opportunity for us to explore what are the ways that we can innovate and scale these kinds of innovations.
Like, I'm hearing both of you talk about all the benefits that remote patient monitoring offers, and the convenience factor, the fact that right now in this middle of pandemic, I don't have to put myself or other people at risk, and by staying at home and so forth. Why do you think it's taken so much time for remote patient monitoring to really gain some traction? Because surely we've had the technology to do it for a long time. Why? But what is it now that's really driving it? Is it just purely COVID, or is there something else behind it?
Well, I think COVID certainly has been an impetus, as Dr. Devereaux had shared. I completely agree. It has put us in a position to really look hard at current mechanisms of healthcare delivery and how can we innovate. But I think there's probably some traditional reasons and historical reasons to why it's been difficult to come to a common language and a common practice around this. I think one is the need, the need for a coordinated strategy. I think a lot of, in recent years, a lot of guidance documents about the topic of remote monitoring and virtual care have been, aspirational and visionary in nature. And we'd all agree that the direction taken around patient empowerment and optimizing efficiency are important, but it's really getting down to sharing important lessons learned about operationalizing these types of innovations and what are the best practices. So I think it's been the nature of innovation for innovators to work in locally oriented clusters, to think through innovations, and these have happened in many pockets simultaneously. And so I think that's beginning to change. There's a lot of efforts being made in the province, for example. The Ministry of Health Digital Health Playbook, is really beginning to challenge people to come up with a common set of offerings around what are the best practices for operational and technical rollout of these kinds of innovations. And so that helps us think about what is a common framing for thinking through practical things like cybersecurity issues, integration with hospital information systems, frequency of contact with patients, and so on. As Dr. Devereaux and I frequently discuss, is also the fact that we need really strong evidence base to base these decisions on. And so, the field is evolving, but we're yet to realize large clinical trial data that are published to inform the best decisions possible so we can make the right kinds of investments in remote monitoring strategies.
Anything to add there, Dr. Devereaux?
Well, just in terms of your question around, why haven't we seen this sooner? I mean, there's a lot of things. It's sometimes, the reality is the healthcare system is busy. The healthcare system can be all-consuming, and at times you get comfortable doing the things and all the way that we've been trained to do things. And sometimes it takes something coming along that says you're going to have to do it another way to get people to move into another direction, and recognize in that process, wow, like there's some alternative ways we could have been doing things and can do things moving forward that, really can be more efficient and potentially more effective. So I think, the reality is change is difficult for everyone. The healthcare system is a very big, machine, and sometimes you need a push to start launching in a new direction. And, as I said, despite the downsides of COVID, there have been some upsides, and I think this has been one of the upsides.
Yeah, I parallels very much what's happened with telehealth and virtual care. I mean, I think before the pandemic, a lot of people said, "Well, that's nice and it is sort of convenient," but I like to see my patients face to face, and I think a lot of patients would have said, "I like to see my physicians face to face." And then the pandemic hits, and then now they're forced to use telehealth, and now everyone's going, "Wow, it's actually a lot more convenient than I thought it was, and actually a lot easier than I thought it was." It sounds like remote patient monitoring is experiencing the same kind of effect, where people are now realizing it's not as hard or as arduous as maybe people thought it was before, and the technology now is definitely up to speed and up to par with what the needs are.
Yeah, and also too, like, it's important to recognize there definitely will always be times that we need to see patients. Just what you also realize in doing this type of work is that there's lots of times that, in fact, you can take care of things virtually and remotely. So, I think that that's also an important thing for everyone to remember. It's never going to completely replace in-person care, but there's a lot of stuff that can, in fact, be done virtually, and there's some big upsides to that.
Well, and let's get into that a little bit. You're currently doing some research in partnership with a company called Clouddx, which they do make remote patient monitoring tools. Can you maybe describe for us what you're investigating?
So when the pandemic started, right away, hospitals across Canada basically sort of canceled their elective surgeries. We were trying to keep people out of the hospital so that there would be beds for COVID patients, and also trying to minimize bringing people to environments where there would be probably higher risk of getting COVID disease. At the same time, there was a need to keep doing emergency surgery. So if someone had a road trauma, they need surgery, urgent surgery, so if someone has a hip fracture, and also semi-urgent surgeries if you have a cancer that we don't want to leave and have it metastasize on you. So those surgeries had to continue. One of the challenges with those surgeries is that about 1 in 4 of those patients that have that type of major surgery, when they leave the hospital, 1 in 4 of them in the next 30 days are going to come back to the emergency room or be readmitted to the hospital. So we wanted to find a way to say, could we actually decrease that so that, again, we would keep the hospitals, not being blocked up for COVID patients and minimize people's risk of getting this, and also in the process, could we in fact just improve the outcomes for these patients? And so we then designed a trial where we randomized patients to normal care, which is patients typically see their surgeon anywhere between 2 and 8 weeks after surgery. It varies by the surgical discipline and the individual surgeon. So you either had normal follow-up, or you had normal follow-up with a follow-up process that provided virtual care and remote automated monitoring. And the way that worked was we worked with Clouddx, which is a Canadian company. One thing that's important to point out is that, Dr. McGillion and myself, we don't have investment in Clouddx. We've worked with many companies using remote automated monitoring technology. Clouddx is a Canadian company, and I do think that it has enormous potential that this could become a real leader, in the health technology field. And obviously that'd be wonderful if that happened for a Canadian company. But with this company, what we did was we obtained a tablet from them. So we give every patient a tablet. The tablet would give patients 24 hours a day access to a nurse and a physician, and by that, their surgeon. And every day for the first 15 days, a nurse would interact with the patient. They would do a review of systems, and plus the patient could raise any issues they have. And at the same time, we also gave some remote monitoring technology that was very simple to use, where patients would just put a cuff around their wrist, hit a button, it would measure their blood pressure, their heart rate, the respiratory rate. They'd put a little probe on their finger, would measure their oxygen saturation. They put a little probe in their ear, we get their temperature, and a scale, and we get those measurements several times a day. If the patient had certain symptoms or the parameters of their vital signs were past certain thresholds, or the nurse just had other concerns, then the nurse would escalate the care to a perioperative physician that was one assigned each week. And then those physicians then could virtually interact with the patient. They could order prescriptions as needed. They could call the pharmacy, have it delivered to the patient's house. Or they could say, hey, I think you're sick enough, or there's a big enough problem, you're gonna have to come to a clinic, or in the worst case scenario, come back to the hospital. And this persisted for 30 days. After 15 days, the nurses interacted with the patient every other day unless their vital signs showed abnormalities. And we're seeing whether or not, in fact, that can in fact improve the outcomes and minimize the need for people to come back to the hospital, because hopefully what we do is identify problems much earlier, treat them before they become big problems, and hopefully that can improve the outcome. Plus, as I said, we can get into it later on, you see in examples of just convenience for patients in terms of dealing with things.
Sounds like a pretty interesting study that you guys are doing there. And just to clarify a couple of things, when the interaction that the patient has with the nurse, is that through a video chat, or is that asynchronous through text? What is that interaction like between the nurse and the patient, through the tablet?
So I can respond to that. So in the intervention structure, so the patient goes home with the tablet, and there's a scheduled video visit that is arranged each day. So the patient logs in and has this scheduled interaction with the nurse, and that can be altered. So one of the things that we did build in, for example, is there's time in the morning where nurses can review the patient data, and if they see something of concern, they can reprioritize the order of those video visits for the day. So it allows for flexibility to be responsive in terms of the data coming in, which has operationally worked well for us.
Cool. And how large is the study that you're doing? What's the size of the group that you're looking at?
We just recently finished the randomization, so it was a record timeline, which is also one of the things that was very positive about COVID. So we randomized 905 patients in 8 centers across Canada to either get normal follow-up or follow-up that provided virtual care and remote automated monitoring.
Wow, that's quite a large trial. Thank you. And can you share any sort of observations or early thoughts or results from what you've done so far?
Do you want me to start on that, Mike, or do you want to start?
Sure, I'll follow you about our interviews.
Okay, I'll just say a couple of quick things. The first thing is, we don't know what the trial result will be. However, I will share 2 cases that I think will highlight to most people where you can see value even in individual cases, let alone knowing the overall effect.
Okay.
So, one example is where we create enormous convenience and efficiency for patients. So there was a patient in Hamilton, or this patient lived in Niagara Falls but came to Hamilton and had a urological procedure. The patient then went home, and on a Saturday night, the patient was starting to have a lot of pain, and the patient then just presses a button and is able to virtually interact with our nurse. The nurse, I was the physician on call for this week, and the nurse, because the patient had a lot of pain, the nurse then contacted me, And then again, like in a matter of minutes, I'm virtually now interacting with the patient who's in Niagara Falls. I already know all the patient's information because we've been following the patient from the time that they've left the hospital. And this patient has very severe pain on their side of their abdomen. They also have increased frequency of urination, and they have burning on urination. And this sounds like it is a urinary tract and kidney infection. And so this is like 9:30 on a Saturday night, and I'm able to phone a pharmacy right by the patient's house and order the antibiotics for this patient, and also organize for this patient the next day to go to a local lab in the outpatient setting, do a urinalysis, which then subsequently confirmed the infection that we were confident the patient had. Now, the alternative to this is that this patient who had like 8 to 9 out of 10 pain, is in a lot of pain. Their alternatives on Saturday night is either to go to a hospital in Niagara Falls where they didn't have surgery, so the physicians there, are at somewhat of a disadvantage because they won't know all of the information that happened, or could drive all the way back to Hamilton, which is, about an hour's drive, and wait again in the emergency room there for 3 to 6 hours to be seen, and then assess, versus we're able to deal with this in an incredibly rapid way, fully knowing the patient. And I think most people hearing that case, I certainly know myself, when this case happened, I'm thinking, there's no doubt in my mind, I want this for my loved ones, because this is just a much more effective and convenient way. And also, in the middle of COVID, it avoids my loved one or this patient having to go back with one of their loved ones into a hospital setting and be at risk of being exposed to COVID. So I think, that case highlights, just at an obvious level, that is very convenient and efficient and effective in terms of what happened. Another case can highlight, I think, the benefits that can happen from the interventions where things could go very wrong. A patient who had had heart surgery in the trial was an elderly gentleman, went home. And the first day he went home, all of his vitals and everything was fine. And then on the second day, his heart rate was about 32 beats per minute, which is very low. And as soon as that comes in, it's an automatic flag to the nurse that we have a vital sign that's substantially out of whack. The nurse then contacts the patient, and this was an elderly gentleman, and his wife was also elderly, answered them this interaction and said, look, dear, he was doing great yesterday, but today he's exhausted. He just told me he wants to sleep. He did the vitals and he really doesn't want to be bothered. And I'm just going to let him sleep today. And so the nurse then has to escalate this care to the physicians who are on call because it's out of whack. And the physicians then again insist on contacting back to the wife, and they explain that they need to see the patient. And when in seeing the patient, it's clear that the patient is not simply tired, but they have decreased level of consciousness. An ambulance is organized, the patient goes to the hospital, is found to be in complete heart block, and emergently gets a pacemaker. Now, it's possible that this patient could have done okay till the next day, or the wife got nervous enough and just insisted, calls an ambulance. At the same time, this patient could have actually died and had a very poor outcome. So again, you see those kind of cases that it makes you realize, what can be happening and how you can be missing it when you don't have that ability to monitor patients remotely. So those are just two examples, which individual cases that show there are real potential for people to benefit from this technology. I think, though, we need, the research like the trials we're doing to figure out really the cost of, efficiency and effectiveness, and also sort of just how do we do this optimally. But for certain, I've seen cases where I think it's difficult to deny that individual patients benefited from the structure that existed with the virtual care and remote monitoring that we were providing.
Dr. McGillion?
Thank you. I think, and to follow on those case examples, one of the things we're being attentive to doing is, alongside the outcomes for the trial, is to really look carefully at what is the experience of patients and families in the home, what is the experience of the clinicians involved in delivering the intervention, the nurses and physicians who are engaged in that shared care model. And this helps us only to learn how best to refine the workflows, both on the patient and clinician end of remote monitoring. And so in those interviews, which are underway at the moment, we're just about halfway completed the interviews of patients and families, and we're asking for, the good and the bad. What is your experience? We're connecting with you right in your home. What is that like? And what we're learning from that is that patients and families are telling us they really value the immediacy of access to knowledge and expertise, particularly when they're in doubt about, they have a symptom or they feel something might be wrong. Sometimes patients are in a state of doubt. Should I go to an emergency room? Should I not? They also have concern for overutilizing healthcare resources. And so something that's coming out is that the reassurance that's associated with having immediate access to knowledge and expertise and guidance. So patients and families are also telling us that they feel comfortable because and value that they're able to stay at home, particularly in this pandemic. They're concerned about if they go to a hospital, for example, unnecessarily when something could have been dealt with remotely. And so when we ask about what are the perceived disadvantages for patient and family, thus far that we haven't heard anything. I think that, again, convenience is also pointed out in a number of the interviews. So we'll continue to learn as we do those interviews and look forward to sharing what else we find.
And both of what you gentlemen have just related is just it validates, I think, a lot of what people assume these technologies would be able to do. The convenience, the life-saving factor, the reassurance, and the prevention of overutilization of the healthcare resources. I mean, these are all benefits that remote patient monitoring are supposed to deliver, and it's reassuring that you're seeing some of that borne out through the study that you're conducting. I do have to ask, though, was there at any time did anyone bring up any privacy concerns, or was it just sort of assumed that everything was going to be right, and the convenience just sort of trumped all of that?
So we do ask about what is perception around, do you feel this is an invasion of your privacy? And we haven't seen that as a priority for patients recovering from surgery. They highly value the connection. That the ability to connect from home certainly has superseded. But I think that's also, you raise a good point, Colin, is that when you design these kinds of interventions, you have to be attentive to what is the privacy and security of the system you're setting up. And back to the earlier part of our conversation, I think as we accrue more data and learn more through our studies, we're able to share experience around what is that best practice to safeguard patient and family privacy in these kinds of deployments.
And I think, another thing to keep in mind with this is that for certain there's, people who will raise this and make this a big issue. And for certain, it's true that for some patients, it is an issue. In the same way that some patients don't even seek Western medicine. But the reality is the vast majority of people in our societies do seek Western medicine. And my observation is that the vast majority of people, first and foremost, want efficient and effective healthcare. And, the reality is everything we do has some inherent risk. And, when you consider, what the reality is of what people put into social media versus the, checks and balances that exist in terms of ensuring privacy of this, I think the reality is what we see is that the vast majority of patients just think that, this is this is a very acceptable low risk endeavor and potential upsides. But importantly, we should always be clear, no one would ever be forced to do it. If people don't want to do it, they're more than welcome not to do it. There'll always be some, but from what we saw, that seems to be very uncommon.
Yeah, I certainly think that it shouldn't be an either or question. Do I want care? Do I want privacy? But the two, you should have both. And I think most of the systems, like the ones provided by Clouddx, cater to and ensure the privacy of patient data as much as they can. But there always is, as you put it, an inherent risk to any of this stuff. But I think, to your point, most people find that risk acceptable in return for what I'm getting, right? The care, the convenience, the reassurance. I think it's an acceptable, it's no more risky than anything else I'm doing online in terms of banking, in terms of email and so forth. So it's interesting that you're asking that question, first of all, and second of all, that again, your data is bearing out the fact that that is not a big, huge concern about adopting this technology. Because I got to be honest, when you talk about in the initial days of talking about remote patient monitoring, that was a perceived barrier, that there's no way patients will want this, because who wants, in the United States, it'd be like, who wants my insurance company to have access to my vitals, or who else is looking at this stuff at the hospital end? And I think what people have now realized is that's simply not the case. People are way too busy to be just looking randomly at some patient's vitals. I mean, you're going to be your care team that's looking at your vitals, and you'd want them to in order to catch those situations that you're just talking about. So I'm glad to hear that we've kind of progressed past the discussions around privacy.
Yeah, and I think also too, this is an important issue. Whenever people are having surgery, you have to have an informed consent process that explains what is the potential benefit of the surgery, what are the potential risks. And we're often involved with patients on the informing the risk side from a, risk to your heart, risk to other complications. But one of the things I remind people of all the time is that, we need to realize there's risk in things you do every day, so that none of us typically think about it, but when we get in a car and drive, either as the driver or passenger, there's real risk. You could be in an accident. But the reality is you've come to accept that to do what you want to do in life and enjoy life, you're going to accept that risk. And if you get in an accident, you don't think that you were crazy to be driving. You're upset, disappointed, but it's just a recognition that to live life the way we want to live it, we're going to do that. And I think it's like most of these things, when a lot of times people start off by talking about, you should be frightened of this, but then eventually what people see is what are all the upsides, and eventually that starts to dissipate. It won't be true for everyone, and again, people can make their own choice, but I do think when you put it in the context of what people do willingly share, just randomly, without, the same kind of upside for your own personal health, I think most people from our observations in this research area make the choice that this is a very positive trade-off.
Well, I'm definitely looking forward to seeing the results of this study. I mean, it'll be both the quantitative stuff around whether or not it impacts outcomes for the patients, but also some of this qualitative commentary from patients on their perception of remote patient monitoring and these interventions. To me, that's equally compelling reading because there is a concern about the acceptance level of this type of technology in the patient population, which kind of leads me to my next question. Like, now that you've done a lot of work in this area, both in population health sense and also just around these technologies, what do you think needs to be done to improve the adoption and make RPM, or remote patient monitoring, more ingrained in healthcare in general?
So I think Dr. Devereaux and I both agree, and our colleagues as well, that it's about delivering robust evidence about what are the best ways to engage in remote monitoring and what is its impact on patient outcomes and experience. And so, as we referred to earlier in the discussion, I think there's been, a couple of decades of a lot of innovative, thoughtful pilot work around the technical aspects of, the measurement devices, the security aspects, the integration. All of those important fundamentals have allowed this field to mature. But where we are taking it, and what really needs to happen, is the large-scale clinical trial evidence to really inform the decisions. That's what's going to drive the direction we move forward in terms of policy and investment in these kinds of solutions.
Dr. Devereaux?
I agree with Dr. McGillion, and just add that to me, I don't see virtual care and remote automated monitoring going away. But where we need a lot of work is to figure out how to do it most effectively, efficiently, and in a cost-effective way. And it's like every area of healthcare. I believe if you put smart people on any topic and you spend time doing it, seeing patients, sorting things out, you'll find ways to make things better. And I'm convinced that's what's going to happen with virtual care and remote automated monitoring technology. But basically, we need rigorous research that keeps improving the process of how we do this and the efficiency with how we do it. And but I don't see this turning backwards as a clock. It's just there's too many things that are appealing to people about it, and you know, we just need, you know, lots of big studies that really keep helping to refine and hone how to do it optimally.
Excellent. Is there anything that you want to make a comment on or a question I didn't ask that you wish I had as we close off this discussion today?
Nothing further from me. Thank you.
And just, you know, two things. One is just thanking all the people who this trial that we just finished of PBC ran, both patients, but also hospital administrators, all kinds of researchers, just tons of people were needed to make this happen. And I first want to express, you know, both Dr. McGillion and I share the same gratitude to all those people that made this possible. And the reality is clinical research that actually changes clinical care only happens because of a very large team. Secondly is that it's just the importance as a society that we continue to advocate and endorse government investing seriously in research. Number one, we all care about our health. We want to find the most effective and efficient ways to deliver it. And at the same time, it also, in this one example, it has the ability to create industries for Canada. It is possible that in the same way that BlackBerry became a world leader in terms of, you know, technology, it is very possible that Clouddx could do the same thing. And it is really important as a society that we continue to invest in research to both grow our economy, but also make sure that in fact we have the best evidence to inform how to deliver the best healthcare.
Excellent. Well, gentlemen, thank you so much for your time today. I will definitely am looking very much forward to the results of the study and reading the paper and everything that comes from it. Thank you so much for your time, and thank you for sharing all this wonderful information with us.
Thank you so much, Colin.
Thanks, Colin, for having us. Pleasure.
This is Colin Hung with Healthcare IT Today. Thanks for listening.